Hi everyone, welcome to the lesson on colostomy irrigation and stimulation. In this module, you will learn about the procedure known as colostomy irrigation. It is most commonly used by individuals with descending or sigmoid colostomies as a means of regulation of colon function, but can also be used to treat constipation, deliver medications, or clear the colon before a procedure. Fluid, usually tap water, is instilled into the colon, which causes distension. This in turn causes a peristaltic wave, which acts to push the stool out of the body. The purpose is similar to why an enema is given. As noted earlier, the primary purpose of irrigation is to regulate bowel movements, so the bowel function only occurs at the time of irrigation. In this way, individuals regain a sense of control over the bowel action and feel more confident when performing their activities of daily living, have a greater sense of normalcy, and in some instances not require a pouching system over the stoma. Other times, irrigation is used to include cleansing of the colon before or after a diagnostic test, treatment of constipation, or administration of therapeutic solutions. An example of the latter could be an individual with a descending colostomy who is prescribed an antibiotic to treat a sinus infection. The individual subsequently develops C. difficile colitis, and vancomycin is then ordered to give as a bowel instillation. The vancomycin solution would be delivered to the colon through an irrigation. There are several factors that need to be assessed before a patient is even considered as a candidate for irrigation to regulate bowel function. First of all, only descending or sigmoid colostomies have the potential to be regulated this way. The individual's prior bowel activity needs to be reviewed. These individuals who had one bowel action a day or every other day will be the most successful. If someone had multiple bowel actions a day, their bowel function will not be regulated with a once-a-day irrigation. The individual also has to be able to learn how to do an irrigation and be physically able to perform the procedure. Additionally, the person kind of has to want to do it. There needs to be a little self-motivation factor there. Patients are generally not in the hospital long enough to learn how to irrigate, so this has become a procedure that's typically taught in the home or an outpatient clinic setting. Keep in mind that irrigation is a choice. The person can choose to quit irrigating, or they can choose to learn even if years have gone by after the original ostomy surgery. There are some contraindications for irrigating a descending or sigmoid colostomy. It takes approximately 1 month to determine if irrigation will actually lead to regulation of that bowel function. That is, no function of stool between the irrigation. Therefore, individuals with a poor prognosis are likely not to benefit from this procedure. Additionally, individuals whose bowel function in the past has been unpredictable, particularly if their usual bowel activity occurred more than once a day, or those undergoing chemotherapy or radiation, also would not benefit from irrigation. Any residual bowel disease would also be a contraindication. Also, stomal complications such as a prolapse, like you see in the photo on this slide, stenosis of the stoma, basically because the fluid can't be instilled, or peristomal hernia increase the risk of perforation and are therefore reasons to not do irrigation as part of the management method. For some individuals, there are real advantages to doing colostomy irrigation, as they can find a definite time for irrigation with the resulting bowel activity to be of advantage in terms of planning time. It can also free them from the requirement of wearing a pouching system, decrease flatus and odor, as the bowel activity occurs just with irrigation. There's also a limited chance for stool to be in contact with the skin, so there's a decrease in skin problems. Additionally, equipment costs over the course of time will be decreased. Now, once the decision to irrigate for bowel regulation has been made, there are other factors to be considered. The individual should time the irrigation procedure to occur at about the same time their prior bowel activity occurred by means of taking advantage of their body's own natural biorhythms. Potable water should be used for irrigation. If necessary, bottled water can also be used. Now, research has not proven the ideal volume of water to be used for irrigation, but usually irrigation is begun with 500 cc's of water, with the amount being increased to 1,000 cc's. So what indicates when the volume is correct? It's quite individual, of course. It's the volume of water used that keeps the person free from a bowel action until the next irrigation. In other words, there's no leakage of bowel content or stool in between irrigation days. It is appropriate to fill the water bag with more water, which then is used to rinse out the irrigation sleeve. But keep in mind that no more than 1,000 cc's of water should be instilled at any one sitting. Equipment needed includes the water bag, an irrigation cone, a water-soluble lubricant, an irrigation sleeve clip, and a new pouch or stoma cap. Irrigation sleeves are made to attach onto a flange or are held in place with a belt, accordingly based on the type of equipment being used. So let's go through the steps of the procedure. Start by filling the irrigation bag with the appropriate amount of tepid tap water. If water is too hot, it can burn the bowel mucosa. If it's too cold, it can cause excessive cramping. So we want to use tepid tap water. The irrigation bag is placed so that the bottom of the water bag is level with the individual's shoulder as they are seated. The water bag can hang from a shower curtain ring as seen in the middle photo, be suspended from a hanger, or from a hook placed on the bathroom wall. The important point here is that the end of the water bag is at the shoulder level while the person is seated, so that we don't have too much pressure coming from the water as it flows into the colon. Next, clear the air from the tubing, or that is, prime the tubing, because the air could cause some cramping. The individual should apply the irrigation sleeve in place, either removing and properly disposing of a pouch of a two-piece system, then snapping the irrigation sleeve in place, or by removing the prior pouching system, generally a closed-in pouch, and applying the irrigation sleeve around the stoma and securing it in place with a belt. The individual then sits on the commode with the irrigation sleeve positioned between their legs so it can drain into the toilet. Alternately, the individual may sit on a chair facing the commode with the end of the irrigation sleeve resting in the toilet bowl. Now the clock begins. At the end of the irrigation cone is then lubricated with water-soluble lubricant, then the cone is gently inserted into the stoma. The first time the irrigation procedure is performed, the healthcare professional should use a well-lubricated pinky finger and insert into the bowel lumen to determine the direction of the bowel. The cone is then inserted through the open top of the irrigation sleeve and positioned into the bowel lumen in the direction that was determined by the pinky finger earlier in order to facilitate the flow of water. It should take about 10, at most 15 minutes for the fluid to instill. Once the correct volume of water has been instilled, the cone is removed, the top of the irrigation sleeve is securely closed, and the patient waits for return. Have the patient take note of how much time this elapses in this process. So there's an initial return that can last up to about 30 minutes. During this time, the majority of the stool and gas will return to the irrigation sleeve. The individual needs to sit on the toilet during this phase. After a few sessions, most people can generally tell when their initial returns are done. So in other words, they'll get through the learning curve and they'll learn what works for them. At this point, the end of the irrigation sleeve is closed and clipped, and then they wait for a secondary return, which can take up to another half hour. Again, each person will learn from themselves the exact timing of this process. Once the returns are completed, the total time can be anywhere from 30 to 60 minutes. The individual can remove the irrigation sleeve, clean the flange, and snap on a fresh pouch. Or if a belted sleeve is used, the skin is cleansed and a pouch or stoma cap can be applied. Some individuals will find that a commercial stoma cap, which has a built-in gas vent, works well for them. Others can use a large-size commercial adhesive pad or mini pad. The irrigation sleeve should then be cleaned with mild soap and water and left hung to dry, or then it can be put away for storage. Irrigation bags and cones require replacement about once a year. Points to stress with individuals include the use of gentle insertion techniques of the cone because we're trying to prevent perforation. They should use tepid tap water and an unhurried procedure or approach in order to optimize the results. Yes, they're going to be a little nervous initially, but again, once they get through the initial learning curve, they're going to be pros at this and they'll be teaching you. Of course, there are issues that can cause problems for the person who irrigates. The fluid can be difficult to instill or return. Stomal causes that prevent water installation include stenosis and peristomal hernia. The individual should be evaluated by their WOC nurse or surgeon if those two problems occur to determine if surgical intervention is warranted. Individuals may have no outward sign of a hernia and are first aware of its presence when the amount of time to instill water for the return has increased. Additionally, an irritable bowel or hard constipated stool can be present. If the irrigant fails to return, the individual should review their oral fluid intake to determine if they might be dehydrated. Again, keeping in mind the colon mucosa will absorb fluid if the person requires it. Excessive amounts of irrigant may be pushed all the way to the right side of the colon, which also can delay returns. Fecal impaction and colonic spasms are two additional reasons for slow or failure to return of the irrigant. Cramping can be caused by quick installation, too cool of fluid or air in the colon, or bowel hypermotility. The use of liquid colace, also known as aerosol, as a bowel irritant can initiate cramping. Licensed independent practitioners may order the aerosol to be used along with an oil if the person is constipated. More on this in a moment. Be aware that the vasovagal reaction can also occur, so it's important to check with a physician before beginning irrigation if the person has a history of heart problems. Another issue is spillage between irrigation, and this is due most often to dietary indiscretions. So most individuals will learn over time what foods affect their gastrointestinal tract. Some individuals find their GI tract affected when they're emotionally upset, for example. Irrigation errors such as leakage of large amounts of water around the cone during installation can occur. This also will affect irrigation results. Close questioning for changes in technique is helpful to determine issues or problems. So in other words, review the procedure again with the patient if they're having a problem and observe for any complications. And this is the best way you can kind of be a detective to try to figure out what's going on. So over time, people may not pay as close of attention to details when they first learned. And so again, they might need to be re-educated. Also, individuals with colostomies are just as prone to a GI virus as anyone else. So it's important that they have some drainable pouches in storage just in case. As you can see, there are a variety of reasons for a change in bowel function. The root of the cause of the problem needs to be identified and then measures taken to compensate. It may take careful questioning to really figure out what the problem is. So, a colostomy stimulant, as opposed to irrigation, is a procedure done for individuals with a descending or sigmoid colostomy in the postoperative period to assist with return of bowel function. It is indicated when there has been no bowel activity after surgery. Keeping in mind, usual function is expected to begin about 5 to 7 days after the surgery. And the individual is having increased abdominal distension with resultant discomfort. Needed equipment includes water-soluble lubricant, an irrigation sleeve if available, an 18 French or less indwelling catheter, normal saline, and an irrigation set. The purpose of colonic stimulation is to encourage colonic peristalsis. In essence, one is teasing the bowel to help it get started or function again. The water bag is filled with 1,000 cc's of normal saline, and the indwelling catheter is placed into the end of the irrigation or enema tubing. You might find it also are helpful to tape it in place for added security. The tubing is then purged of air. A lubricated pinky finger is gently placed into the bowel lumen to determine its direction. The tip of the indwelling catheter is also lubricated with that water-soluble lubricant and then gently inserted into the bowel lumen. The saline is allowed to slowly flow into the lumen of the bowel as the catheter is gently advanced into the bowel. And again, we can't overemphasize the word gently. Okay, the saline will leak around the catheter, and this is normal. The catheter is inserted its full length, then gently pulled in and out, and this process is continued until the full volume of the saline has been instilled. The catheter is then removed, and the fluid should return within about 10 to 15 minutes, at which time a fresh pouching system can be applied. The stimulation is discontinued if the patient experiences increased abdominal pain or if the catheter is unable to be advanced. Do take note of the volume of solution returned. If there's little to no return, do alert the licensed independent practitioner, as this patient could be dehydrated. Oil irrigations are done for individuals determined to be constipated or impacted. The solution most commonly used is cottonseed oil with an equal amount of aerosol. Aerosol is liquid colace, and it acts as a bowel irritant and can cause intense cramping. So be sure that hard stool is not blocking the lumen of the colon. Mineral oil or vegetable oil can also be used. The oil is instilled using a cone tip, and the usual volume is about 500 cc's. The purpose of the oil is to soften the stool so that it is more easily expelled. You should not expect a large volume of return after the oil is instilled. The more oil that is absorbed into the stool, the better, actually. The irrigation sleeves generally have been thrown away as they are difficult to adequately clean following this procedure. The oil irrigation is always followed the next day with the soap suds or tap water irrigation. On rare occasions, a combination of milk and molasses, known as the black and white irrigation, can also be used for severe constipation. The high amount of sugar in this solution causes fluid to be pulled into the bowel lumen, which softens the stool and thus stimulating peristalsis. Some individuals who have incontinence may benefit from the use of a colonic tip enema. This patient performs the enema to ensure complete emptying of the bowel on a routine basis. By having a cleansed bowel, the stool will not leak. This type of enema tip is used for those with decreased sphincter control. The difference between this and a normal enema is that the ball is present at the end of the tubing. And its purpose is to hold the water in place during installation in order to cause the fluid to distend the colon and cause a peristaltic wave. The individual can then give themselves the enema while lying on their left side or while sitting on the commode. The ball is held against the anus for about 5 minutes after the water is instilled, and then it's removed. If cramps are a problem, the patient simply removes the enema tubing when sitting on the commode, allowing the solution to return. This technique is often done in the hopes of preventing ostomy surgery. This ends the lesson on colostomy, irrigation, and stimulation. For more information, please see the reference listed on this slide. And thank you for your attention.